this talk. Basically, we will go through different pathway, which will start from bedside waveform analysis of intracranial pressure, and then we will discuss the importance of monitoring the ICP targets that we need to keep in neurocritical care patients, indications for ICP, and management of increased intracranial pressure. So what I always say to my fellows when they are in the unit is that the ICP is not just a number, but it is a wave, and therefore it is very, very important that we observe the wave of the intracranial pressure. Don't look just at the number, but look and follow the waveform. And you will see that the ICP has got basically this shape in terms of waveform, where there are three waves. The P1, which is the percussion, the arterial component, which is related to the stroke volume, to the cardiac output. Then there is the P2, which is the tidal wave, which reflects intracranial compliance. And then there is the P3, which is the dicrotic or venous wave, which basically represents the closure of the valve. Why is it so important to look at the waveform? Because already looking at the changes in the waves, you already will see that there are some issues in your patients. This is an example. There is a huge group, a very good group in Brazil, in South America, who is studying a non-invasive method for estimated intracranial pressure using exactly this method, which relies on the relationship between P1 and P2. If you see here, when P2 is higher than P1, it means that the intracranial compliance is not working properly. The second message is that you don't have only to look at the wave. You have to look at the trend of ICP. This is a trend that all of us would like to see during the morning round, because it's a trend of low and stable intracranial pressure. This is a pattern that we don't want to see, because you have an elevated and stable intracranial pressure. And this is a patient where we really have to be aggressive, because otherwise, if you keep refractory intracranial hypertension going, the result is basically brain dead. And this is a real-life neuromonitoring, multimodal neuromonitoring of what happens exactly in this moment. You see, this is our ICM Plus, which is a multimodal monitoring tools. In white, you can see the intracranial pressure. You see that at some point overnight, what happens is that we had an increase in this patient of the intracranial pressure. And despite the therapy, we were not able to reduce the intracranial pressure. You see the map, the arterial blood pressure does not decrease that much. But because the CPP is the relationship between the MAP and the ICP, we had a drop of the CPP, and this means that the brain was not perfused. The green one is the autoregulation parameter, which is the PRX, and as you will see, here it becomes all red. It means that the patient obviously lost completely the autoregulation. But between this very bad situation and the stable ICP, we have different grayscale that it's important that we learn to assess. For example, this is a typical case of a patient who has a high number of slow waves. What are the waves of intracranial pressure? You have to look at the trend and detect whether you can see this, because these reflect as well the intracerebral compliance and the intracerebral physiology. For example, a lumbar wave type A, these are very dangerous, are waves where the amplitude is higher than 50 over, so very high intracranial pressure. They last more than 5 minutes, and they may be related to changes in MAP. And when you see a wave like this, it means that the patient is losing the autoregulatory capacity and is losing the compliance, because what might happen, what generally happens, is that maybe the patient has an episode of reduced arterial blood pressure. The result of this will be a cerebral vasodilation to maintain the cerebral blood flow, but the small increase of the volume will cause an incredible increase of the intracranial pressure. And the reason is that the patient is in the part of the PV curve where the compliance is low, and even very small changes in volume are related to important changes of intracranial pressure. Then you have the Lumberg B waves, which have a lower amplitude, they last less, and then you have the C waves, which are generally related to the breathing and are not dangerous and do not need any treatment. So the effect on outcome of intracranial pressure, a lot of studies regarding the correlation between ICP and outcome, a lot of retrospective or prospective observational study. This is one of the most typical, but basically the majority of these observational studies agreed on the fact that ICP higher than a certain threshold, which is generally 20 millimeters of mercury, is associated with the outcome. Of course, you all know that the only randomized control trial on this topic was a negative trial, and it is the very famous trial from Randall Chestnut. But as you also know, this trial has been a lot discussed regarding the methodology, because basically the patients were randomized in ICP monitoring and imaging clinical examination group, but there was not a protocol of management. So the concept is that it's not just about putting the monitor, it's about treating the patients according to what my monitor is telling me. And the other problem is that it was underpowered for the clinical outcome. So still, we strongly believe that intracranial pressure needs to be managed. And this is what we have tried to explore in this big study. This is a multi-center observational study, which is the S.A.S study that we did with a group of Monza and with the group of the European Society of Intensive Care Medicine, and in particular thanks to Giuseppe Citerio. This study included 146 intensive care units in 42 countries. And basically, it was an observational study where more than 2,300 patients were enrolled with and without ICP monitoring, and different acute brain injured patients were included for this analysis. This is the first message from the S.A.S study, that still, despite a lot of research on this, there is a huge variability across centers regarding the use of intracranial pressure. This is a caterpillar plot that you probably have seen in different studies. Each one of these dots is a country, and this is the mean odds ratio. It means that, this graph means that for the same patients with the same age and the same severity of brain injury, as 4.5 folds the risk of putting or not an ICP monitoring. This means that it really depends on clinical practice. And even in this graph here, you will see, according to the different colors, the probability of, for the same type of patients to receive an ICP monitoring, and you see that there is a large variability. And it's not just about countries, it's really about single centers, because you see there is variability in Europe, there is variability in North America and in South America. Again, we went to explore in this study whether the ICP use was associated with methods and protocols to treat intracranial pressure. So we went to assess the TIL, the therapy intensity levels, and we found that this is a good message, that higher therapy intensity levels are used in patients who are monitored with intracranial pressure. And what we found in terms of outcomes with the S.A.S study is that there is a potential beneficial effect on the use of ICP monitoring in terms of 6 months mortality, not strong or clear effect regarding the neurological outcome, but most importantly, in this model, we put also the therapy intensity level. So it's the concept that I was telling you before. An increment of 1 point in the TIL is associated with a progressive reduction in mortality. So we will discuss this in a few minutes, but the treatment of intracranial pressure and being aggressive sometimes is worth it. And this was consistent according to the different types of acute brain injury, TBI, subarachnoidal hemorrhage, and intracranial hemorrhage. So this is what the us with a level 2B of evidence, which is not a high level of evidence, that to manage severe TBI, we need ICP monitoring to reduce 2 weeks mortality. But which is the target on which we have to treat these patients? These are the guidelines from 2007. And what they say, these guidelines, is that treatment for ICP should be initiated when ICP is above 20. And this is, of course, a joke, but if we read these guidelines, this means that if we have 19, we can go to have a coffee. And if we have 21, we have to treat the patients. Obviously, it's not exactly like this. The new guidelines, those from 2016, haven't really solved this issue, because what they just said is that, no, it's not anymore 20 millimeters of mercury, it's 22 millimeters of mercury. And this change came from one very nice, well-performed, but still one retrospective study, which is this study where basically the threshold for ICP associated with mortality and the poor outcome was evaluated. And as you can see from this graph, it was 22 and it was not 20. So it really didn't change the problem, didn't sort the problem. And Gerd Manfred with this group some years ago produced this very nice paper where they put the concept that the problem is not the number itself, but is about the dose of intracranial pressure. In this graph, on the left, you can see a cohort of adults, and on the right of pediatric patients. And if you see here, in red, it's poor outcome, and in blue and light blue is a good outcome. It's not just about the intensity, so it's not just about the 25 millimeters of mercury that is related to outcome. It is also related to the duration of insult. This means in the clinical practice that if I have a patient with ICP and he has been suctioned by the nurse, and ICP goes to 28 for a few minutes because he's coughing, and then goes back to normal, I'm not very worried. I'm very worried if I have a patient who remains at 22 for many hours, 22, 23, 20 for many hours, because it means that the duration of the insult is very long. When and how to monitor these patients with ICP? So who to monitor? Which are the indications? These are the guidelines from 2007. Which say that severe TBI, so GCS between 3 and 8, and abnormal CT scan are the indications for ICP monitoring, plus other similar condition. The new guidelines have basically downgraded this evidence. As you can see here, they say recommendations are not supported by strong evidence. So again, they didn't really solve much with this guideline, because basically they just mentioned the fact that the level of evidence had to be downgraded regarding the indications. But this indication basically remains. So altered CT, for sure, with severe TBI, so with a GCS between 3 and 8. But there are many gray zones and many situations other than these where clinicians will put an invasive ICP monitoring. This is a survey from the Center TBI study, or centers, and here what was asked to the responders was in which patients would you put an ICP monitoring? The majority, of course, will put ICP monitoring with the indications of the guidelines, so abnormal CT and severe TBI with poor neurology. But there are some centers where, for example, with a poor neurological status, so below 9, but also without CT abnormalities, they will put an ICP monitoring. Or they will put an ICP monitoring in patients with a moderate TBI, so GCS from 9 to 12, but with contusions which are potentially, which can evolve and can potentially cause neuroworsening. Or think about all the situations where you have, for example, a patient with traumatic brain injury, but also thoracic trauma. And in this situation, the patient maybe is not able to do any clinical evaluation because he needs to be sedated and paralyzed because of a chest trauma. Here, probably ICP can be used even if the GCS is not below 9. So there is a lot of variability and a lot of confusion also regarding the indications. Less confusion is about the type of monitoring that we have to use. You know that the gold standard is the intraventricular catheter, which is a catheter that goes in the lateral ventricles. It's very precise. It has a risk of infections, and sometimes it's not so easy to insert it, especially when the brain is very swollen. Otherwise, there is the intraparenchymal catheter, which goes in the brain parenchyma. The infection risk is very, very low. Of course, it measures the local pressure in one point of a brain. And then there are more sophisticated types of measurement. This is the Bolt from Peter Hutchinson in Cambridge, where basically there is with one only hole the possibility to measure ICP, PbTO2, and to do the microdialysis. Why did I say that there are no doubts regarding the type of monitoring? Because a lot of authors have studied non-invasive ICP methods. I'm one of them, so I can tell you that it's a very fascinating topic because ICP is invasive. So in some cases we can have some side effect, bleeding, or maybe the patient may have a coagulopathy and it is too risky to put an invasive ICP monitoring. So there are really a lot of non-invasive intracranial pressure methods that can be used at present. This is a review which describes all of them. The easiest one and those which are most used are those which are based on pupillometer, but all which is gaining interest. Cerebral compliance is gaining interest, but what is most used so far is the use of the ultrasound. So the transcranial Doppler, where there are some formulas like the pulsatility index and the flow velocity diastolic formula, the ONSD, which is the measurement of the optic nerve sheath diameter, and the venous transcranial Doppler. This is a study that we did in Cambridge where we compared all these methods with invasive ICP, and as you can see, these are very nice curves, very nice results. So if you look at these results, and if you look also bigger papers, like this is a meta-analysis that we did published on intensive care medicine on the accuracy of optic nerve sheath diameter, and we observed a very good area under the curve for the detection of intracranial pressure with the ONSD. So it's a fascinating technique, but the problem is that despite non-invasive methods have a lot of good things, they are safe, easy available, low cost, non-invasive, bedside, they also have some limitations. And the limitations is that they are operate independent, that they are ultrasound estimations, so there is an inter-observer variability. They are not as accurate as the invasive methods, but they still have a role in TBI. For example, when you have a patient where you don't know if you want to put ICP or not because is in one of the gray zones, and non-invasive methods can help you to discriminate the patients who are at risk to develop intracranial hypertension. Or in the example that I gave you before, if you have, for example, a patient with coagulopathy or the neurosurgery is not available, you can, in the meantime, use the non-invasive methods. And here we come at the management. I suggest you to read this very nice consensus, which is the Seattle consensus. And basically the concept of this consensus is that to manage intracranial pressure, we have to start from the basics, so from the less aggressive treatment, and then go up to be more and more aggressive. But before starting with strong therapies, we just need to follow the physiology, and we need to be good general intensivists. So here there are three tiers, three staircase approach that we can follow. First of all, what we have to do is to do a good general intensive care. This is the GHOST CAP. It's an acronym that we created with Professor Taccone from Brussels. And it just says that if you remember to treat glycemia, hemoglobin, oxygen, sodium, temperature, to comfort the patient, arterial blood pressure and PaCO2, you've already done the 80% of your work from brain-injured patients. Then, if despite this you have still increased ICP, you can consider to do other things. Tier 1. You can consider to increase sedation, analgesia, for example. You can consider to keep the PaCO2 slightly in the lower limit, like 35, 38. You can consider to use mannitol or hypertonic saline. You can consider different facts, and we will discuss some of them. The hyperosmotic agents, for example, mannitol and hypertonic saline, these are very effective and commonly used. These are the dose of them. The effect of both of them is an osmotic effect, so they increase the plasma osmolarity, so they take out the water from the brain and reduce the brain edema. So good agents, both very effective for ICP management, for intracranial hypertension, no difference in terms of efficacy between mannitol and hypertonic saline. So which is the best? There is not a best in reality, because it really depends on the clinical status of the patients. Hypertonic saline, of course, can cause hypernatremia. Mannitol can cause other side effects. It's a diuretic, so you can have polyuria and you can have a reduction of the arterial blood pressure. So use the one that is more clinically indicated for your specific patients. But be careful, because both are associated with side effect. This is a sub-analysis of a center TBI study where we evaluated the occurrence of acute kidney injury in traumatic brain-injured patients, and both mannitol and hypertonic saline were independently associated with the development of acute kidney injury, and also the increase of sodium above 150 during the first 3 days. Then, if the tier 1 do not work, you can consider to jump to more aggressive strategies like tier 2. And these include neuromuscular paralysis. You can reduce more the CO2, or you can do a MAP challenge to assess the patient's autoregulation. What do I mean? This is a consensus on autoregulation and how to use clinically and at the bedside cerebral autoregulation. Cerebral autoregulation is a wonderful, fascinating concept, but the application of it in the clinical practice is not so clear. So how do I manage patients' autoregulation? And what we decided in this concept is that you have to be pragmatic. This means that if you do a MAP challenge and you increase the arterial blood pressure, if the vasomotor response works, you will have a reduction of ICP, because you will have a vasomotor response with vasoconstriction. If you do a MAP challenge and increase in the arterial blood pressure, the ICP goes up, it means that the patient is not autoregulating. So very simple and very pragmatic. Regarding the CO2 and hyperventilation can importantly influence intracranial pressure. So if you reduce the CO2, of course, you will have a reduction of the cerebral volume, which works very well. Which is the fear of using hyperventilation? Of course, vasoconstriction in the cerebral vessels can increase the cerebral, can be related to cerebral ischemia. This is a physiological study from the group of Cambridge, where basically from 38 to 22 millimeters of mercury, the area in red, which are the area where the CBF is very low, so at risk of cerebral ischemia, increased a lot. But this is at 25 millimeters of mercury. The guidelines are telling us to use a mild hypocapnia. Now there are a lot of physiological studies which basically describe the fact that if you use moderate hyperventilation and not for a very long time, the result will be a reduction of ICP, but absolute preservation of cerebral oxygenation and of a cerebral metabolism. And this is another analysis of a center TBI study. Even in this case, you will see, now you know this caterpillar plot. So these are the different centers. Look how much variability there is in the use of hypercapnia, of hyperventilation, even in patients with ICP monitoring or without ICP monitoring. But what we found in this study is that being in a center which tends to hyperventilate more does not worsen the outcome. So hyperventilation with these parameters recommended in the guidelines can be used quite safely. Of course, be careful if you have an additional monitoring like PbTO2, use it if you use hyperventilation, but it can be used. And below these values, only if the patient is at high risk of herniation. Now, we are in the very last part of this talk because we are at the tier 3 therapies. We are in the moment where ICP is not under control despite tier 0, 1, and 2. So we need to be aggressive and we need to use what we call the bombs. So the pentotal or thiopenton, barbiturates, secondary craniectomy or mild hypothermia. This is a very interesting trial, which is the Eurotherm trial, which compared the patients using hypothermia versus a control group. And this trial demonstrated a damage in terms of the use of hypothermia for these patients. But because if you look at the methodology, hypothermia was used very early. It was basically compared to a treatment based on the osmotic therapy. So I'm not surprised by the results of this trial. And this is the Polar study, which is a trial that basically demonstrated it was a negative trial. So prophylactic hypothermia does not work to improve the outcome. Same concept regarding the timing for the compressive craniectomy. This is the DECRA study, randomized control trial, which randomized patients very early within 15 minutes of increased ICP. Results are that outcome is worse in patients who underwent the compressive craniectomy because they had more side effect. This is another trial still on the compressive craniectomy, but in this case, the compressive craniectomy was done after the medical treatment. If you see the protocol here, they went through medical treatment of stage 1, tier 2, and only if this failed, they underwent the compressive craniectomy. And in fact, this trial demonstrated a benefit in the use of the compressive craniectomy on mortality. So the concept is that you have to use the right therapy in the right time, in the right moment. If you use a strong weapon, if you use a bomb to kill a mouse, you will kill the mouse, but you will also hurt yourself. This is basically the concept of a tier 3 therapies. But when used with the right time, as we demonstrated in this sub-analysis of a synapse use study, the effect on outcome can be good. So this is a representation of what I told you. You start from tier 0, and only when all the tier 2 have failed, you go to tier 3 therapies. At this point, which is the tier 3 therapies to be used? Well, you have to think about the patients. For example, if you have a surgical issue, of course, the compressive craniotomy can be the easiest decision. If you have, for example, subarachnoidal hemorrhage or contusions, which respond very well to hypothermia, you can consider that. It really depends on the clinical status of the patients. But the concept is that you need to follow a staircase approach, where for each step that you do, you also have an increased risks of side effect. Even in the tier 3, there is a huge variability across the different studies and centers. This is a center TBI sub-analysis, and this is again your MORE. So your caterpillar, look how much is the variability of the use of tier 3 therapies across different neurotrauma centers. And there is a huge variability also in the timing of using these strategies. And what we noticed in this study is that the staircase approach is not always well used, because these are the use of extreme therapies on day 1, day 3, and day 7. And as you can see, there is not yet really an escalation in the clinical practice. This is my, I think, last slide. I conclude telling you what is not recommended for ICP management. And this is a very nice list, which includes, for example, routine use of steroids, scheduled infusion of hyperosmolar therapy, routine therapeutic hypothermia, etc., etc. And it's still the Seattle consensus that I suggest you to read. And here are my conclusions. So monitoring ICP can improve the outcome of the patients. Consider it not as a number, but as a trend. And consider that the clinical approach must be a staircase approach, considering the potential risks, and the more aggressive treatment should be evaluated case by case after that the medical and previous treatment have failed. Thank you very much for your attention.
Thank you, Chiara, for this amazing talk. Really, you can see that you're an expert. And I would like to start the question by asking you, what is your opinion about the Brain for Care device that is now trying to assess intracranial pressure in a non-invasive way?
So my idea is basically what I was mentioning before, so that non-invasive methods are promising, are good because they are bedside, easy available. My concern regarding them is about the accuracy of measuring ICP, and still we cannot say that we have a method that is accurate enough to substitute invasive ICP monitoring. So the suggestion is to use ICP monitoring in severe patients, and then you can use the non-invasive methods together with it, or in borderline situations where you don't know if the patient really needs an invasive method or not.
Great. Do you use ascending jugular catheter for brain metabolism?
The jugular catheter, you said?
Yeah.
The jugular catheter, you asked me?
Yes.
Yeah. So we don't use it because we mainly use the PbTO2 for the cerebral oxygenation. Despite I think that we really should go a bit more back to the jugular bulb saturation, because it's a very fascinating neuromonitoring tool. It has been abandoned because it was invasive, but it gave only global ideas of cerebral desaturations, because it was not super easy to be inserted. And now people use more the PbTO2, but I think we should go back to use also that.
Indeed, it's really about a multimodal monitoring using many approaches to try to help your patient.
Yeah. Well,
I don't think I have many more questions, Chiara. I thank you very much for your time. And
thank you. It was a pleasure to me.
Hope to see you in Milan during the SIM conference.
Oh, yes. I'll see you in Milan. Thank you very much to all of you.
Bye-bye.
Bye.